many as what we've seen in the previous surge. So I want to say thank you, therefore, to the team, health workers. And that's really the first reason. That's the first reason for us visiting the institutions. We went to visit KwaZulu-Natal yesterday, and tomorrow we're going to be visiting Limpopo, because these are the areas where we're seeing a lot of pressure. We did visit Western Cape a while back and Eastern Cape, and so we want to be able to see what else needs to be done for you to be able to respond. Now, as I have been listening, I have been impressed with the fact that you are sticking to a very strict protocol of managing the COVID-19, and I've seen the level. In fact, even more impressed with the kind of ops room that you're running to look at how the flow of patients and all the challenges that have to be dealt with. I've also been impressed to see the level of participation by all different levels, including management, onto solving the problems that are coming on the ground. It is for me very, very important that from the first COVID patient, and I recall that very well because I was in Pietermaritzburg to deal with the crisis in a school when the first patient was reported. And of course, the next patient was reported in Gauteng. That's when we realized that there was a whole team of friends that actually had been together in Italy at that point. That's now history. It's a kind of history that's so far behind us that is now almost out of our memory. You know, Professor Mutara, we went to Polokwane, and there was a lot of fear when we were going to receive people who were not infected. They had no COVID infection, but everyone was so nervous about COVID-19. So that, I think, is just part of the history that we've been through as we move. I'm also quite, I've been listening, and one of the issues I've been concerned with is the whole issue of staffing, because every now and again we come across this problem. And so I think it's important that we do everything to employ additional staff. Yes, contract posts last time were to do that, and at some point, in fact, some of the staff was actually employed by head office. Directly were to just go and contract staff and bring them into hospitals. And as a few hospital managers woke up and found there were nurses who said, "We've been sent to come and work," and some of them said, "We don't know you," and we said, "Yes, you don't know them, but they are here to help you." So that's the issue. I think it's important because of the other issue that you have raised. The problem of exhaustion is real, and the problem of exhaustion has actually hit us more because. To be honest, this surge came much faster than we anticipated, and it became worse than we actually initially expected. And this partly has also got to do with the degree of complacency at a level of society when we start dropping the mask, start going to big parties, and so on. Part of the reason why you're seeing more young people coming in is also because of the behavior when younger people kind of got into activities that were super spreader activities. So those are some of the things that we have looked at as we're talking now. Now we've also seen that there is a new variant which is tending to be more highly transmissible than the previous variant, and therefore that means that at any one time more people are infected than before. It doesn't mean that it makes the disease more severe, but if you have got a group of people who are infected and they are more in number, many more people will be more severe because of the large numbers, not necessarily because the virus has inflicted worse manifestation into the individual. So that we need to always clarify, because it's important for us to understand that to contain this virus, we need to do exactly what we did before so that we can actually reduce the impact. So that way, the numbers of people who are infected will be fewer, the number of people who have severe infection will be fewer with the variant in present. So we mustn't sit and think that this variant is going to make we've got no way of dealing with it. If we were strict on the masks and distancing and use of sanitizers, we would actually defeat the same variant in the way we defeated the first wave. And so that message needs to come very strongly. And it's important to make that message very strong, because the exhaustion comes from too many people getting positive, getting sick, getting admitted, getting very severe, and needing more and more attention, because everything happened at the same time, with too many people getting infected at the same time. So we do anticipate that there is a problem of exhaustion. We also do understand as well that you have to do your best to try and create space for rest, for shifting people around so that they can find a way to cope. We have to defeat this surge as well. We need to see it over. We need to see, quite a bit of normalization in the way we run the health services. A number of facilities have had to delay the elective surgery and some of the chronic treatment and some of the preventative work, family planning, immunizations. They tend to be affected because of all of this. So we need to understand, therefore, when we ask people to be very strict with the use of masks and sanitizers and so on, we're doing that because ultimately it's got a knock-on effect on other ailments, and therefore we end up someone else who's going to succumb onto something that we could have treated, simply because we had everyone now focusing on COVID-19. The other diseases still cause a lot of illness. The other diseases cause a lot of death. So we can't just let go and say we're just going to focus on COVID-19. So that, for me, is an issue. We have to accept that the issue of exhaustion is a very, very important issue for us. And so it does impact on the size of staff, the numbers of people who are available, and so on. Experienced and as confident as our members are at this point. And that's why I think it's important to raise this issue. Then, of course, we've seen that with the new experience, there's an early intervention in the use of oxygen that saved a lot of people. Now, that way, we've started to find that there's a lot of pressure on the utilization of oxygen. And we went to Steve Biko, we looked around and we saw a lot of cylinders which are being brought in every now and again. Even the oxygen manufacturing plants are under a lot of pressure, but we need oxygen. We need oxygen in all the hospitals. We need the oxygen at casualty, at the outpatients. We need oxygen in district hospitals. We need oxygen everywhere. And we're trying to do our very best to make sure that that oxygen is available, because that's what saves lives. And all of us with the experience, we now know that's what you do. High-flown oxygen, you use it ahead of even having to we use it ahead of having to put people into the ICU. There are many people who actually turn away from ICU because they were given adequate attention with oxygen. It taxes a lot from the individual to care. When you've got people who are under such severe situation and you are also under your own pressure, anxiety, it's even more exhausting. So that issue it's an important issue. So we've noted, therefore, all your efforts towards the psychosocial support, even at work, even to give them space to move out into their homes. And we must understand that when someone gets off from work, they now go into a full-time responsibility as a family member, as a parent, as a father, as a mother, as a carer of the members of the family. And when you get there, there are new problems that you have to face, and therefore it's always very important that you must understand that we can't sustain continuous exhaustion of our members. So we thank you for all the work you do, the psychological counseling that you do, and I think that all the hospitals have tried to now find a space to be able to deal with this particular issue. This issue of certificates for staff and writing the names, I think is also very, very good. At this point, we have got over 51,000 health workers who have actually tested positive, and probably just under 600 that who have lost their lives. We really, feel very sad about this, and we always want to convey our condolences to the parents, to the friends, to the colleagues, to everyone who has lost their loved ones during this difficult time. Of course, it's always an issue because we have seen that the numbers of people who are positive gets higher amongst health workers who are in the community where the positivity rate is in any case high, because we meet as part of the community. When you're in the community, you are not wearing a PPE. You therefore get exposed, and so that becomes some of the challenges. Something that has happened this time around, excuse me, is the filling of the private hospitals ahead of the public hospital. Now, this issue, we're still trying to understand how does it happen, because in the previous surge, we had an earlier attention focused on the private hospitals, but soon thereafter the public hospitals took over. So I've been very uncertain as to what this means in terms of the movement of this pandemic. But at this point, we've actually had to get patients referred from private sector to public hospital, whereas before we had made an agreement to actually refer all our patients to the private hospital, in particular to the ICUs. So there's something here which we have to start and analyze and see what would have happened in this case. We saw this first time in the Eastern Cape. In the Eastern Cape, private hospitals were full. We actually ended up with patients with medical aids going to be treated in the hospital which was put up, the field hospital put up by VW in the Eastern Cape, and therefore we realized that we need to collaborate between public and private. Doesn't matter where the person lands, they must actually find that this system does not create fault lines where people can fall into cracks simply because your private hospital is unable to take you. Doesn't mean that you must now suffer. You need to then find a way of being treated in the other hospital. But I must also say that the reputation also of this hospital has been quite good in terms of treatment. Outside this, we actually follow a number of patients that we become aware of and discuss with the members. Professor May, every now and again, I would actually be calling him in the middle of the night, sending him text messages, and he would come back. The amount of dedication that we have seen is actually unbelievable. So we do want to say thank you for all of that. So you are now watching the movement in the numbers of patients, and therefore we are able to open up beds ahead of the surge. That's the way. What we found even in the previous surge. You can make all the plans about COVID-19. Wait until it happens. That's when the plans are going to be actually happening, because you only know then what is the impact, what's the number. In Steve Biko Hospital, the CEO was saying, everything was quiet and everybody was fine. And on one Saturday, 3 patients came in, and the following day there were 19 patients. After that, it was like a storm. So you can only plan for COVID-19 by being ready to move speedily, to actually act and shift and make sure things are able to accommodate your rising flow of patients. So from that point of view, I am very pleased to hear, Prof. Was that's the issue that I wanted us to deal with, and that's the issue of the observation wards. That's what tends to create an impression that the hospital is full. If you get a bottleneck there, then people feel that, particularly the ambulance services, then they start panicking to say they can't put a patient in because the hospital is full. When in fact the wards are open, but the triage system is such that the observation wards are delaying the movement of people. Now you've got the question, because I asked the question and I knew you knew where I was going to as well, because the real issue is that we've introduced antigen test, which is a rapid test. So what that does, it allows you within 15 minutes to be able to determine whether the person is positive or not. And for those who are positive, they can move on quickly, no problem. You might then wait to recheck the ones who are negative, but it actually opens up your wards. And I'm glad that your system is actually allowing that and is flowing properly. So that, for me, is an issue. So we have to keep watching the numbers. MEC, the 4,000 beds, we're expecting, for example, that when there's pressure, excuse me, the NASREC must be able to take those convalescent patients in so that it can open up space for intensive treatment for those who need to be taken into the main hospitals. Now that way the system is working well, because then all you do is that this one is not ready to go home but doesn't need so much care, but we need the bed, move them to NASREC and so on. Then when you do so, the field hospitals are doing what they were meant for. Then after a few days they'll be discharged, but what it means therefore that we can always deal with the flux of the patients that are coming in beforehand. So that for me is important. The challenges about the period of stay in hospital, if we have the numbers increasing, that's when we start getting a lot of problems, because if you've got too many people who are sick, the percentage of those who are severe will be higher, and therefore those will spend longer in the ICU, and that's more, it costs more in terms of human resources, in terms of treatment, in terms of all the equipment and so on. So we keep watching now as to what else needs to be done to actually make sure that we improve. At least the presence, the introduction of dexamethasone was quite helpful to reduce the level of the mortality at that level. But when someone gets to the ICU, it's not easy. It's usually very, very difficult, because those individuals tend to have a much more severe situation that requires a lot of support. So we do want to say to our people, we know it's difficult that you've got someone who comes to hospital and they cannot be visited. Because for us, even if you are sick, if your relatives come and visit you, it then becomes easier for you to bear the pain because you got the support. Now, once you go into the hospital and you don't get that support from your family, sometimes you can't even phone. I had a friend who was in hospital, and I spoke to him, and I could realize that he was having a difficulty with breathing. The consultant who came in after that called me and said, no, we took your friend's cell phone away. We told him that part of the treatment is stop talking on the phone because of the pressure. In other words, now the connection with the families and friends is actually interrupted by the treatment. We understand that. It's very, very difficult. We understand that. But even the question of people coming in to visit, people who are in the ward, is very difficult. For a nurse, for a doctor, for anyone who cares for those, has to go through quite a process to get themselves into the PPEs and change from the dirty area to a clean area and reverse and so on, until they are able to get out of the hospital knowing that they haven't spread the infection. Imagine now for the 200 patients that you've got, each one with one visitor, it means you'll have to change PPEs 200 times. If we've got 3 visiting hours per day, it's going to be 3 times of that amount. Now, it could have been easier if we just put on a PPE. But if you make a mistake and you then end up breaking the cycle of infection control, you now are going to take the infection from here and go home. Many people who have not been trained would actually put us into that problem. So we do want our people to understand that it is very difficult, but that's the only way we can manage this situation. And then, of course, it takes me then to the one issue, and that is, if we look at the trends, for the past few days, we went as high as recording over 20,000 people were positive per day. Those numbers have started receding a little bit. We believe that that is an indication of effective use of masks, of sanitizers, of distancing. That's what is actually making that impact. So we would like people to continue to do what they've just been doing well. Because as a result of that, we're waiting to see how Gauteng is going to cope. Gauteng last time went up to about 3 times higher than the peak that was in KwaZulu-Natal, maybe 2.5 times, and even more than what happened in Cape Town, in Western Cape, and more than what happened in Eastern Cape. This time around, we've seen slightly different trends. In the Western Cape, the surge started early, but instead of that surge, it was almost to the same peak with the previous one, except it's lasted much longer. So even though the numbers were no longer increasing in the Eastern Cape, you couldn't feel that there's a difference in the numbers, simply because it was continuing at a high level plateau. It's now kind of coming down. But you'll also understand that when that happens, the level of illnesses drags a bit longer, because people will be sick even if there are fewer. So it will drag longer for another 2 weeks or so, depending on how severe, so it drags a bit long. And therefore the deaths also do the same. Then the Western Cape surged to a level which is almost twice the size that it was in the first surge. And then at some point we had very optimistically, the Eastern Cape team was saying, well, they think they are now coming down. But actually what happened was a plateau at that peak. So the plateau at a peak was still a peak, and therefore it's actually taken quite a while. In the past few days, it's shown a trend downwards, which is very promising. So now in KwaZulu-Natal went almost higher than where Gauteng was during the peak, which was quite unexpected. But at the same time, we've seen that now in the past few days, there's a slight decline. And that decline, we believe that it was going to be because of the movement of people, the migration of people away from the holidays, and that the peak was also occasioned by the fact that a lot of people actually tend to use the coastal provinces to visit. Eastern Cape was saved by the fact that the lockdown came a bit earlier, and therefore there was quite a lot of restriction in terms of the spread of the infection. Now Gauteng has started showing a slight trend downwards. We're holding our fingers crossed, because in the first instance, it's still too soon to know what is the impact of the people who come from all over, particularly the coastal provinces, which had a high level of infection. Now, what then happens to them when they come back to Gauteng? And some of them have gone to Limpopo. We've seen Limpopo has already shot higher than the previous peak, the previous surge. So they will be all coming back now to Gauteng. So we are waiting to see what the impact is going to be. For another week or so, if we keep the trend, that means we might be slowly getting out of the surge. But if the impact of those who are infected was still incubating, then of course we're still within that time when those numbers can still show up. So if we didn't institute the level 3 modified approach in terms of restrictions, we would have been worse off. And I think it's important for all of us to understand that we have been saved because of the very strong restrictions that we have all had to endure in the process. But lastly, I can never say it better than how Prof and the CEO have said it. Alcohol, irresponsible consumption of alcohol tends to create unnecessary and avoidable accidents. In the case of this suspension of the sale of alcohol, literally all the major hospitals have got the same response. They have seen huge reduction in the acute trauma, in emergencies, in interpersonal violence, stab wounds, gunshot wounds, motor vehicle accidents, large taxi accidents where you've got a number of people killed at the same time, and so on. That actually has helped in the fight against COVID-19. And that means, therefore, that we have been able this time around to assist and support our health workers. It is most frustrating and actually disheartening when you've got people who are sick, and then you have got people who are not only avoidable in the causation of their accident, but they're also, some of them, abusive. And this is what we have actually had. Abusive. The pressure on our health workers is so severe that this time around it had to be done. And we are saying we are still very high. So no one must now suggest that, well, if you think that the numbers are going down, why don't you reduce? We're actually, unfortunately, peaked too high. So even the reduction has not even reached the peak which we were in July. So we're still very far up. So it doesn't mean that even though we think the trends are coming down, we have actually come to a point where we say, okay, take off your mask and you can stop it. We're not anywhere near that. We're simply just saying we have to encourage society, all South Africans, that what you are doing now is making an impact. Please keep that up. What we're also saying, when we said people, please give us a sacrifice, no alcohol for a while, that has actually saved our health workers and have actually opened up space for us to treat quite a ravaging pandemic, which has gone into many hospitals 2 times, 3 times, or even 4 times higher than what we're seeing before. So that is really what has been, for us, a very important message for the day. So I'd like to leave it at that for now, and I'm sure that we have answered all your questions, and therefore, thank you. So we want to give to MEC.
About the vaccine.
No, all right, we'll talk about vaccine, but let's get if there's a question. All right, let me quickly talk about vaccine issues. Firstly, I would like to say that to the health workers, in particular, one of the most important reinforcement in your own protection is going to be administration of the vaccine. We prepared to ensure that this is done to serve to save the lives of all the South Africans, and therefore we talk about what we call herd immunity. There are 2 issues here. One is personal immunity, one is herd immunity. Personal immunity is what the administration of the vaccine to the health professionals, to the frontline workers is all about, so that each one person can have ability to generate immunity to avoid getting the infection themselves. But herd immunity means if in this room so many of us have got the immunity through the vaccine, that means the few who may not be having that immunity are safer because the others are immune. That basically means it reduces the risk of someone getting the infection and therefore spreading it to the next person. Of course, we still have to look at a lot of other issues about it. There are issues around pregnant women. There are issues around, people under 18. There are issues around how to deal with those who might have had infection and so on. That the science is going to clear. But we still want to insist on our undertaking that at the moment our programs, processes are on course to ensure that before the end of the month we receive the first batch of the vaccines. Then, of course, we hope that beginning of February we'll be able to start getting to administer these vaccines. There is quite a lot of work that's been done, and I'm sure in the next day or 2 the President will also be announcing additional support in terms of all the plans that we are dealing with. And so the availability of vaccines is our first priority. Secondly, we have a number of, we indicated the 1.5 million. We also have the 12 million that is coming from the COVAX facility, and we actually have signed up for the J&J vaccine, but we're still negotiating, but we have signed that up. We're going through negotiations. It's very difficult, but we're going through that. There are others that we have signed up for. We're not going to talk about them. We will announce them when time comes, just to indicate that we actually are moving on with our program of acquisition of vaccine. We must also say that throughout the whole world, the challenge of the speed of manufacturing is where the bottlenecks are. We have actually seen countries, it was in the media as well, where some countries have been saying they are pushing the manufacturers to honor their delivery schedule. So we do understand that there will be that situation. But we want to indicate that South Africa is not delayed. we actually are well within our cause to be able to do that. All of this vaccination is supposed to happen on 2021, and a lot of countries are going to be focusing on that as the year when the vaccination will happen. So the vaccination issues are on course. It's also important, you've heard about the fake news of how all of a sudden all the news houses are going to be running about the hospitals that are full, and they actually are convinced that this is so, and it's not necessarily so. When we go into details, because of the social media, you tend to get lots of myths that come up. We've got a similar situation with the vaccines. Some are saying, well, the vaccines come from the devil, and some have said the vaccines are coming from the 5G and so on. Some of these are myths that we really need to clear, because people read these things and they do get concerned, and they get very concerned and worried. In some, it does have to be, some even health workers who are very concerned to say, oh, okay, what about the issues of side effects and so on? We will monitor everyone who is vaccinated to make sure that if there's any record of adverse effects of the following the immunization, that we actually record that and deal with it. Every drug, doesn't matter how safe it is, has got some precautions about that it can cause some side effects, and therefore we have to always make sure we monitor that. From the clinical side, we don't worry about that. We always know we can observe, and then we can deal with it if something arises. So I do want to assure as well our fellow South Africans that the vaccines have gone through trials that will make them safe for administration to humans. If they were not safe, they would not have been even allowed to move on to that point. So that would be the situation. Then the last point that I think your question about ivermectin, I've seen a few of you want to ask that question. We have said that as it stands, ivermectin has been registered for the use in animals, and therefore there was a call earlier on in the when COVID-19 came about, which was saying we may not have enough time to invent new medicines. Let's look at the existing medication, whether there are any ones that could be put on trial so that we could actually check whether they are useful against COVID-19. And therefore, we expect there were a lot of those that were tried. Our guide is WHO, that WHO has actually not recommended the use of ivermectin. Now, what tends to be a challenge when you sit with any medication is that there will be reports of people who are improving. There will be reports of various forms of responses to medication. Now, what we need to register the medication, we need to make sure that we go through a kind of properly structured trials, so that you don't end up with a situation where the media would be turning around and say, but you didn't follow the right procedure. Now, when there are side effects, then how do you account for that? So that's what we're dealing with. So what we have then said, our South African Health Products Regulatory Authority, SAPRA, has said those, like the ivermectin, needs to be subjected to those trials, so that you are able to work out the clear advantage that it's got over the other medication, or even over the placebo. But also, it needs to be a trial that is properly conducted. So if we call from the public to say, register this drug, we are calling outside the way that it gets to be done. So we are looking at a team that must, pull further all these studies, because 3 weeks ago, the Ministerial Advisory Team, together with SAPRA, they pulled all the available research documents and analyzed them, and felt that we had not come to a point where it can be registered. But if anyone, doctor, wishes to use it, there is also a special arrangement that you can do to apply to for the drug to be made available on Section 21. Now that doctors know, if there is some drug that is used somewhere that is properly structured to be used for humans, and you have got evidence to believe that it can be used, you can use that kind of application. In the meantime, excuse me, in the meantime, we're going to be getting the teams to relook at all the all the available information to deal with this matter. We're aware of the outcry. We're aware of all the issues that people have raised amongst the community, among some of the doctors, and so on. But we need to actually get the proper process to be able to ensure that all the risks that are associated with it are actually clearly outlined, and the registration process can be followed. Let me leave it at that. Thank you very much.
Thank you, Minister. Did NEC want to say anything before we take questions?
No, thank you very much. I think the Minister has covered quite.
Thanks, NEC. Okay, colleagues, it is 6:30. I still have to go and do the daily statement. So please, can we try and ask questions that have not been covered in the Minister's address? We'll start with the State Broadcaster, Criselda. Thank you.
Good evening. It's Criselda Lewis from SABC Television. Minister, I'd like to ask pertaining to the expected surge, in particular here in Gauteng. From what you have observed thus far, do you think facilities in the province will be able to handle this expected surge, given the fact that hospitals, I guess such as this one, have highlighted issues pertaining to staffing in the particular COVID wards, which you've also expressed concern about? And on the issue of alcohol, we saw the Barra statement. We see Prof has also spoken quite widely about it. We see the effects of what this hospital says they've gone through, something they haven't gone through in many years as a result of the banning of alcohol. Would you be advising your colleagues for perhaps an extension of this ban beyond what we're seeing currently, given what you're seeing as Health Minister of the country?
All the questions? Introduce yourself.
Sure, my name is Yashil Panchia. I'm a freelance journalist who's registered with the Foreign Correspondents Association. I'm asking a question on behalf of many of the media present today, and also border bodies. And I wouldn't be asking if we didn't mention something earlier about the conditions in hospitals only being learned from social media. We sent a letter through as members of the media last week Friday, raising concerns about hospital access, and it's been an issue that's been ongoing, and we're just awaiting a response from that. But it's not fair to say, like, part of the reason why the public isn't getting all the information and only getting it from social media is because media are being stonewalled with access without protocols, like without guidance from the DOH. And many medical personnel that we're trying to speak to are not able to speak to us, or being told they can't. So I'd just like to comment from the Minister about that. Thank you.
Thank you. So just to clarify, you're talking about media accessing hospital facilities themselves and the staff in the facilities,
yes,
within the facilities.
Within best practice
within the
in terms
facilities.
of safety
Okay,
and the rest.
I just wanted to clarify that. Thank you.
Sure.
Any other questions? No? Thank you.
And all the questions.
Wonderful, wonderful. Thank you. Minister, I just want to say that letter, we actually received it yesterday, and it is in the process that it should start. So I just want to just add to what Tommy said.
Okay, look, I haven't seen the letter, so we'll discuss it and see what it's all about. Let me just say that in principle, and by the way, I've seen lots of media documentaries where the staff was interviewed. They complained about shortage of staff, PPEs, and dirty hospitals, and management. They complained about department, the minister, and everybody. I've not seen that there was a problem in them talking about it, but also we've seen unions raising the issues as such. If you want someone to speak on behalf of the hospital, then you have to deal with the management, you have to deal with the authorized voice. But if someone was talking on the streets about what they are seeing and so on, I'm not sure. So I'll look at your letter, and I'm not sure what you're dealing with. However, there are specific requests which we sometimes get very uneasy about. Firstly, the showing of patients under examination and you see people opening their mouths and their swabs are being thrown into their nose, and it shows as a kind of, repetitive thing and so on, it's actually not acceptable. It's a very serious breach of the human rights. So there are those restrictions which we would like media to also understand. If you do some of that, you either get the permission from the individual, or you actually make sure that their faces are identified and so on and so on. So those would be some of the issues that you might come across when you feel there's a bit of tension and people aren't free to let you go in. The second one, there's a team we went with to Steve Biko Academic Hospital, and we said to them, don't cross the line. Now they don't see the line because it's not visible. Now we know there's a line here. So the problem is that there are areas which are restricted, which is risky for the journalist to go into if they've got to end up coming back. Because for people to be there, everyone knows you don't cross this line, because those who are that side have got a particular protocol to prevent the infection. So sometimes we will restrict you because of that. And some of the areas we actually, and one time I was a bit uncomfortable where I saw the report of the media and so on. I mean, okay, he's wearing a PPE, but the camera is fully exposed. Now, they go into a ward, which was a COVID positive ward, and I said, you know what? You're actually exposing a lot of people into a risk. So I think when we deal with the question of access, we need to look at some of those basic protocols, because that's where the issues are. Then we can take the issue beyond that. But I'm not debating. I'm sorry. I'm just going to answer this question. I will respond to your letter. I'm just explaining. We can't do a dialogue. We can talk outside. So the issue is that we do expect the media to record what they find, what they hear, and in this COVID-19, media has done quite well to report a lot of issues. Of course, in some instances, there are things that do go wrong in the way that things are reported. So when I talk about fake news, now it's always tricky. Do you report fake news as something that you have seen, or you do report it as fact, and so on? So it's something that we need to find a way to deal with. So insofar as your concerns are, we will follow the matter up based on the letter. I'm just making an explanation so that you must know. We don't often get the time to actually say this to the media, to say there are lines that we shouldn't be crossing, and therefore it's important. It's like the distancing. It's very difficult to get the media to distance. As we sit here now, we've been here for almost 2 hours. You can't get people to be afar. They are one overlapping shoulders like that. It is still a risk. And we must know, and sometimes we have to decide, do we continue with this thing or we don't? Because someone's going to turn around and say, oh, look at they're actually not distancing. But what we worry about is that if any one of you becomes positive, or any one of us becomes positive, now you become contacts. So these are some of the issues. But nevertheless, we do want to see media covering the issues. And there is nothing to hide about challenges in a hospital. There is nothing to hide if things have gone wrong. We have to deal with them and solve them. Some of them might be difficult to solve, but we're not saying that the media must not have access to the hospital. But there are these restrictions that we have to take into account. So we'll follow your letter up. The last questions. Yes, I'm confident. At this point, I'm confident that the provinces will do their best to deal with the numbers. They have done so up to now. But of course, you need to understand that it depends how many people come at any one time. So, as I was saying, that in some cases, you have to prepare for the increasing numbers. So they must stay ahead of the pack by, if you had 100 beds last time, now you're going beyond 250. But you don't know whether you're going to need 250. You first open up another 30, and then they get fill up, you open another 50, and then so on. So we actually, I am confident that we will handle. Not that things won't go wrong, there will be problems here and there, but nevertheless, this team and this health system, with all the weaknesses, is the one that has actually helped to deal with the health of our people. There will be problems that you may not be able to solve, but that does not mean that we'll actually be unable to respond to the issues as they arise. And that's really what the situation is. You've had the the talk here was about getting contract workers and so on. There will always be a way of responding to the problem until we are able to resolve all the problems. My view, to resolve all these problems, we need everyone to support national health insurance. Then you will see the coordination that is needed. Like if you talk about in the UK, they're running national health system. It's the NHI sort of the sort that they're running there. You need that. You need a situation where everybody works together in a coordinated way. Now, there are lots of people who are not happy with that, but it's unfair. It's unjust. You have to get to a point where there's equity in health, and then NHI is the way. Then the question around alcohol. Well, we don't have an issue. We're not sitting here saying people must never drink alcohol. We are saying the suspension of alcohol has had the desired effect of reducing pressure to the health workers to the extent that they are now able to attend to a surge of unpredictable numbers that we've had to face. If we're still facing the surge, we'd like to see that our focus must go to unavoidable problems such as the infection, then avoidable situations like what the alcohol would have caused. We're not at the point where we're making any recommendation, so I can't comment on what recommendation will be made, because I don't even know when that is going to be. But we're watching these numbers. These numbers are beginning to improve, and mainly because I believe the use of masks and distancing, but we're not anywhere near where we should be to be able to start saying things are fine. We are not. Thank you very much.
Thank you, colleagues. Thank you, Minister. Let's close the briefing.
CEO, you guys have read too. Minister, you still want to do a walkabout?
Short one.
The minister will do a short walkabout. Maybe we'll just go to 161, which is near. You answered all the things that we are going to.
I know, because there are burning issues.
The chief of staff is here.
I'm the only one
But everything is
Hi, Sudha, how are you? I'm fine, thanks.
Sorry. Yeah.
She's gone on a walkabout.
Oh, okay.
Anyway, let's go shoot a look outside.
Okay, cool.
so then there's no use.
I think we're done. King, you guys will want to do walkabout. We are good with walkabout. We've got enough.
No, fuck. Yeah. It's a 2 of our team's biggest hospital.
Oh, yeah.
Just fine. It's still
Yeah,
light at least.
yeah, there's still a light.
We're going to have to be quick about this. I'm not going to send it for subbing, we're just going to shoot it.
Oh, okay, cool. I think we can use the entrance here.
Yeah,
Yeah.
you can do it at the entrance with Charlotte behind it.
Uh,
Oh,
let me see. I know there's no sign here.
there's a sign over here.
Yeah.
It's up to you, let me help you here, sorry.
Yeah, just hold this. Oh, this one outside, yeah?
Yeah. Dumelang. Thank you. Alrighty. Which one do you want? That one or this one?
I'll just do it that way.
That one.
Yeah, you see a light.
Cool. Oh yeah, it's a nice light.
Yeah.
The Health Minister undertook a site visit to two of Gauteng's biggest healthcare facilities. Steve Biko and Charlotte Mkhize Academic Hospitals. He's confident of Gauteng's readiness. He's confident of Gauteng's readiness. Deal with the surge. But Mkhize says it's still too early to be able to say what the migration of holidaymakers back to Gauteng will do to the province. He believes the downward trend in infections is an indication of the effective use of non-pharmaceutical interventions. Meanwhile, the CEO of this hospital